All right, well, I think it's 5 o'clock, so we'll go ahead and get started. Everyone, welcome to our panel discussion, Strategizing Non-Traditional Approaches to Research. We have a great group of panelists, and hopefully you will find this session informative. My name is Sophia Sheikh. I am faculty at the University of Florida, College of Medicine in Jacksonville, Florida. I am also medical director for the Florida U.S. Virgin Island Poison Information Control Center that's also located in Jacksonville, Florida. My research interests include opioid abuse and overdose risk, pharmacogenomics, and pain. I received funding from the NIA through a KL2 type grant from my university, funding from SAMHSA and various other non-for-profit foundation groups. The objectives of our session today are to review the different investigator stages and how to maximize the benefits for each group. We will also review the role of a program officer and the best practices when communicating with your PO. And finally, we will review the key resources within NIH for investigators. So as I mentioned, I will be moderating today's session as well as my co-moderator, Dr. Govinda Rajan. She is the Associate Vice Chair and Associate Professor of Emergency Medicine at Stanford University School of Medicine. She's a health service researcher with a focus on stroke systems of care and pre-hospital care. Currently, she is funded by the Agency for Healthcare Research and Quality to study the causal effects of stroke systems of care on thrombolytic use. Her previous work related to pre-hospital stroke care has been funded by the American Heart Stroke Association, Foundation, and Agency for Healthcare Research and Quality, and she collaborates with the health policy scientists at the CDC. She is a member of SAEM, AWAM leadership, and gender equity programs at Stanford, and has mentored many female early stage investigators. I will now introduce the rest of our panel group today. We have Dr. Rosemary Fernandez, who's an associate professor in emergency medicine and the research director for the Center for Experiential Learning and Simulation at the University of Florida. Dr. Fernandez has expertise in healthcare team performance research. She has been principal investigator on grants funded by the Agency for Healthcare Research and Quality, the Department of Defense, and the state of Washington. She serves as the decision editor for the journal Simulation in Healthcare and for ACEP Open. Dr. Fernandez serves as a mentor for both research and education-focused faculty in academics. We also have Dr. Marie Carmel Ellie. I don't know if she joined us yet, but she is a faculty at the University of Florida in the Department of Emergency Medicine, Division of Critical Care, as well as the Department of Medicine, Division of Palliative Medicine. She's also the Chief Medical Officer of Haven Hospice. She is soon to be appointed as the new chairwoman of the Department of Emergency Medicine at the University of Alabama in Birmingham. I will let Prasha take over now and she'll introduce our NIH representatives.
Thank you, Dr. Sheikh, for the nice introductions. And before I jump in and start to introduce our panelists, I would like to highlight the efforts that Dr. Sheikh and also my colleague, Dr. Angela Lumber-Brown, who is a pediatric emergency physician at Stanford and a research expert on traumatic brain injury in children in designing this panel. Although Dr. Lumber-Brown contributed many hours of her time to this panel discussion, she's not able to join us today due to a family medical emergency. And I would also like to thank my chair, Dr. Andra Blomkans, who is here with us in the audience and has been a tremendous source of support for all of us at Stanford. And now to moving on to the introductions, I have the honor of introducing two important individuals from the National Institutes of Health, Dr. Jane Scott and Dr. Jeremy Brown. Dr. Jane Scott is the director of the Office of Research Training and Career Development within the Division of Cardiovascular Sciences in the NHLBI of the National Institutes of Health. I've known Dr. Jane Scott for a few years now, and during these years, she served as an excellent resource and a mentor for me, as well as for many of our SAEM members and investigators. She's attended our annual meetings. She's been on panel discussions for about 15 years plus. She's been a strong advocate for emergency care research and training programs in emergency care, and is always willing to meet with our trainees who are interested in emergency care research opportunities and a research career in emergency medicine. Dr. Jeremy Brown is director of the Office of Emergency Care Research, where he leads the efforts to coordinate many funding opportunities for emergency care research at the National Institutes of Health. He also represents the government-led efforts to improve emergency care throughout the country. And in addition to these important roles, he also serves as a medical officer for the Siren Emergency Care Research Network that's supported by both NINDS and NHLBI, and for many other grants that are focused on emergency care. And before coming to the National Institutes of Health, Dr. Brown served as the research director at the George Washington University's Department of Emergency Medicine and has had a successful track record of NIH funding. So with that, I will close the introductions and move on to questions. And my first question, it will be to Dr. Jane Scott. So Dr. Jane Scott, there is more than one way to engage in emergency care research. And for some, the ultimate goal of this training is to achieve research independence while advancing science. And for others, they like to engage in collaborations rather than being the PI on grants. So can you talk a little bit about the different training opportunities for young investigators or early stage investigators and trainees in emergency care?
Certainly, I'm happy to address that. I think here are my slides, and it's what interests you and when do you want to start. Most people have, the people that I see, that I talk with, will call, and they have, sometimes they're coming in late, they're late assistant professors. Other people have known they want to be scientists since they were in junior high school, and they can tell you what their history is. So the goal is finding a program for the individual that will meet their needs. I think it's really important that individuals understand what they want out of research in terms of a career. Do they want to be independent investigators, or do they want to be a teammate on do they want to be a team member? Do they want to write papers and help with other research? So that's a really important marker. Which way do you want to go? How much? Because the NIH R01 training trajectory is 5 to 7 years on a regular basis. You do get salary, you get protected time, you get to do research during that time, but a lot of people find that too daunting, in which case there are some other options. For example, we're going to talk about postdoctoral research training, T32 training, that are affiliated with fellowship programs. There are T32 programs affiliated with cardiology, not so much at this point in time with emergency care research, but it's a wonderful opportunity because those programs provide 2 to 3 years of research training for individuals who are just finishing up their clinical and they're interested in pursuing research. And by the end of the program, they know whether or not they want to continue.
Thank you.
Thank you, Dr. Scott. Dr. Fernandez, can you tell us a little bit about your research path and any advice that you might have for people who are starting out in their career, in your experience with having a K grant and leading to a successful independent career? And also kind of framing that with how one's path to research independence can look different depending on their background, their experience, and what institution they're coming from.
Sure, I will try to get to all of that. So thank you for having me. I began in a pretty non-traditional way. I started actually as a Howard Hughes Fellow in basic science. And the reason that's non-traditional is because I now do team science training and work in areas of patient safety. So I started out, I did a fellowship between my second and third years of medical school. I had always intended to be a basic scientist, and at the time, there wasn't a lot available for emergency physicians. So when I finished my residency, I took a year to figure out exactly what the right pathway was. During that year, I somehow was what some might call derailed, but I ended up in residency leadership, but never really lost an interest in research. And as I started doing simulation-based training, I realized that simulation is just another laboratory. And so I really wanted to learn how to use simulation to ask the questions that I wanted to ask around how we deliver clinical care. And so I was lucky enough to receive an Emergency Medicine Patient Safety Foundation training grant, which was just a single year. And I had expected to use that to launch into a K. So I never actually did a K because I was fortunate enough to be awarded an R18 from AHRQ in the interim. So I went for my EMPSF grant and started writing almost immediately when I got into that grant, and then received an R18, which soon led to a DoD grant. So that kind of was my pattern. I would go back and forth from AHRQ to the Department of Defense, and was able to parlay that into a career. Looking back, had I known what I know, there are aspects of a K award that would still be appealing to me. The opportunity to dedicate time to really hone some specific methodologies that maybe I always need to partner with others on, that I could have incorporated myself. But that's been my path. I think I would just say that there is no untraditional path. We tend to think of the traditional path as K to R, but I think understanding where you want to end up, to echo Dr. Scott, if you don't know where you want to end up, you could end up either wasting time or just having regret that you didn't do the things that you wanted to do. And I think some of that goes to mentorship, just to understand what your career will look like. It's not unusual for somebody to decide they want to do the K to R pathway, and then kind of decide that they don't really want to spend their lives writing grants or leading a team. They'd rather be part of a team and have a little bit more balance between the missions of emergency medicine and their career. So I think the one thing that I would echo is what Dr. Scott started with, is know where you want to end up, and then figure out how to get there, and how to get there with balance in your life, so that you can have a family, have a career. It doesn't have to happen immediately, and be willing to sacrifice some other things, but not your well-being.
Excellent point.
Did I get everything?
Yeah, I think you did. I think you brought some good points, and it's really interesting, the career path that you kind of led, and I think that gives some insight to the different pathways, that there's not just one type of pathway per se.
So Dr. Jane Scott, I'm going to build on the previous question that I asked about the research paths, and we have a diverse audience. We have trainees, we have doctors who have just finished clinical training and launching research careers, and we have strongly funded researchers in the audience, and leaders who are supporting many of their research trainees. So the first question, kind of basic question, is, if as a resident I'm interested in a research career, how do I launch it? What's my pathway to research training? And how many years should I be planning to get trained for?
Okay, so if you're a resident, I would look around for any available opportunities for you to take within your institution. You're never too early to learn about research and start understanding what it takes to have a research career. Meet the people around you in your department or in other departments who are NIH or DoD funded investigators, and you can find, or AHRQ investigators. And there are a number of search engines you can use to find out that these individuals have had funding. They're really credible as scientists, and that they're what they're willing to commit to you and what they're telling you is really on the money. So you really want to know that you're getting your advice from people who are really well versed in the field. And then you want to figure out what is the topical area you want to go in. And it may be that you just want that 2-year T32, but that is at a fellowship level. That is the residency training. Until 2 years ago, we never had residency training. NIH started to train some residents, but those programs are so in their infancy at this point that we have no information as to whether or not they're beneficial. So I would suggest, like what cardiology does, what pulmonary does, is that they go into a fellowship program for their clinical training, and then they line up a T32 position for a couple of years. Many of those programs are linked to their board residency. But for example, the AHRQ T32 programs are there, they're available. You just need to know how to find them and understand that they are, that you're a viable candidate for those programs.
And then kind of building on that, can you talk a little bit about a T32 programs? How many T32 programs exist? A little bit about the history of T32 programs. How does emergency care research programs compare to other specialties? What is it that we have to do to kind of increase the number of T32 programs within emergency care research? And what are some of the lessons we could learn from the other specialties to increase those numbers? And this is, a question to Dr. Jane Scott and Dr. Jeremy Brown.
Okay. And Dr. Manish Shah is in your audience, and he would be superb at answering it as well. So the question is, say it again, please.
Yeah, happy to.
Oh,
what is
yeah.
the T32, the
Yeah.
basic? Because as I said, this is a diverse audience, and some of this may be new for the first time. People may be hearing about these. So I just want to start with that and ask what a T32 is. And then how many T32s are housed within departments of emergency medicine, and how do we compare with some of the other specialties?
Okay.
And how do we grow?
NIH at any given time funds approximately 3,200 T32 programs. Roughly half of them are pre-doctoral programs, and then the others are postdoctoral training. I work in the cardiovascular division. I see a lot of T32s that are aligned with cardiology fellowship programs. And those fellows do 2 years in their clinical training for subspecialty boarding, and then they have 2 years of research training, and sometimes they'll have 3 years of research training if they're lucky. But they then, from there, with a 3rd year, they're competitive for applying for a K award or to the KL2 program. It's that T32s are a wonderful jumping off position. Now, I know that in my portfolio, I've got 40 or 50 T32 grants that are cardiology specific. And at the same time, I have the NHLBI T32 programs in emergency care research, and we currently have 3. And they've all developed in the last 7 or 8 years. Lynn Richardson at Mount Sinai, Cliff Calloway at Pittsburgh, and we have a brand new program at Harvard, and it's in it's in resuscitation science, and I'm blanking on the PI's name, but those are 3 programs that are up and going. So there aren't that many T32 programs specifically in emergency care research. However, there are programs in epidemiology, health services research. They're just not lined up with the clinical disciplines. Maybe in 10 or 15 years, there will be enough T32 training programs to bring people up through the ranks. but right now it doesn't exist. We're trying to work that way. I know that with the K-12 program that we've run since 2011, we've funded approximately, I think, 7 or 8 research programs across the country, and the individuals who ran those programs did a really wonderful job. We partnered them with a co-PI who was also a principal investigator of another T32, so that the emergency medicine investigators had somebody with them all the time who knew how to run these programs. And so they came out, they ran really good programs, and they learned very quickly how to run these programs. Anything else?
I was going to ask Dr. Brown for his thoughts, comments
Sure.
about
So,
T32.
One of the challenges with NIH for the emergency medicine community is emergency physicians do everything. We're not specialized within the ED. You don't have the privilege of saying, this isn't my area of expertise, so I'm going to call somebody else. I remember I once got a consult as a physician in the ED for a rather severe corneal abrasion. And I'm not kidding you, the ophthalmologist who was on call called me up and said, I'm a posterior eye person. I don't do anterior eyes. And yes, it's true. And we don't have that ability, thankfully. But NIH is siloed into really disease-focused institutes. And the problem is that we think that we should get trained in all kinds of emergency medicine, but when you think about a T32 program and several other kinds of programs, you have to say, I'm going to do a T32, a training program, I'm going to create one, but it's not going to be in emergency medicine because nobody funds all emergency medicine. It could be in, as Jane was saying, and Lynn Richardson's programming in cardiovascular emergencies. That's funded by Heart, Lung, and Blood. You could foresee, and I had some discussions earlier today about a similar program, for example, for neurological emergencies that the Neurological Institute might fund, or a T32 in pediatric emergencies, because we do have a pediatric institute. So that's the way that we have to think about going forward. These T32s are not going to be in all of emergency medicine. They can't be. They will be supported by the institute and focus on the specific areas of interest. But I think that's fine. We will be okay. And there is even a National Eye Institute at NIH. And if they want to fund a T32 in anterior eye corneal abrasion emergencies, then maybe we'll see that as well.
Thank you, Dr. Brown. I'm going to hand the mic off to Sophia for some questions to Dr. Fernandez.
So we talked about a little bit about people who are early on, maybe in their residency or fellowship, and they know they have an idea they want to pursue a research career, a research path. Dr. Fernandez, I was hoping to get your thoughts on, well, what if there's somebody, as a mentor, if somebody approaches you and says, hey, I'm further along in my career, maybe they're already on faculty and have been so for a few years, and now they have the ability or interest to pursue a research career. What kind of advice would you give that person? And also advise on how to approach their chair to get support for them to pursue that type of path.
Sure. So again, once the actual endpoint is defined, I think then you want to think about how your goals match the goals of your department. So understanding where you want to end up, and then understanding why your chair, and there are several chairs and leaders on this call that can answer this probably better than I, but how does what you want align with what they want? And how will you make yourself valuable to someone besides yourself, quite honestly? So will you mentor junior faculty when you get to your endpoint? Will you be able to position your department to be a leader in clinical trial work? And will you be an important site for Siren or some other similar network? Or will you be an independent investigator that elevates your department in terms of reputation, output, and be able to contribute to novel clinical therapies? So I think some of it is really understanding, and that's going to look different for different chairs at different places. And you have to be a little bit flexible, and then know when, if your goal is just to go K to R and that's not enmeshed and not shared with your chair, then you need to think about moving somewhere else. But that's not, that's when you also say, okay, how do I get to be what I want to be? And maybe it doesn't have an R01 after it. Maybe it's foundational funding. Maybe it's, partnering with other people and just taking a sub lead on some of their projects. I think it can be challenging, but talking with your chair early on is probably the other piece of advice. And then having strong mentorship. So having mentors who can help guide you both in terms of your research, but also in terms of how to structure that conversation with your chair or leadership.
And since you brought up mentorship, and I know you mentor several people, and there's a give and take with that type of relationship. How would we go about finding a successful mentoring team? Aligning our research interests with another faculty member, whether it's at our institution or another institution. How do we go about finding that type of support and kind of leveraging the benefits of that relationship, or things opportunities that relationship might present to us, and how we can leverage that to be successful in our careers?
Sure. Well, I will answer a side question first. I will say that regardless of where you want to end up, I think you want to use the sort of the NIH recipe for getting a mentorship team. So it's never about one mentor. It's always about who your team is going to be. And that can shift and change over the years. But think about who your team should be. And then how do you find these people? I found mine by cold calling them. Now that the internet is up and established and robust, one doesn't need to do that, but that's what I did. And, reaching out, finding people on papers that have similar interests, talking to people at AWEM, at SAEM, asking to have half an hour of their time and just having a conversation. I don't know people in science that haven't benefited from others. So I can't imagine that anyone wouldn't talk to a junior faculty member. And then just listen. I think listening to what they have to say. And a lot of times people approach me and I'm not the right person for them, but then I help them find the right person. So it's knowing that if somebody says no to you in terms of mentorship, they're actually giving you a gift, because they're saying, I'm not going to waste your time with me because I'm not the right person, but I will help you find that person. And it's, like I said, it's almost always a team. I do think that sometimes actually program officers have a lot of knowledge and can share some of that. Going to meetings, not only SAEM, but sometimes in your subject matter area can be very helpful. And looking at who's coached others. So who's mentored others in that area, because successful mentorship begets successful mentorship. So if you find somebody that has, 5K mentees in their past, they might actually not be able to take you on because maybe they're, a good mentor knows when they're at their limits, but they will understand what a successful mentor will look like for you. So somebody who is a strong mentor for K mentees knows what that looks like and will be able to direct you in the right direction.
Great answers. Thank you so much. I do have more questions on my list, but I'm going to pick one from the audience. This is Dr. Chris Bennett, who's an early stage investigator at Stanford. And his question is, what are Dr. Scott's and Brown's, and this is also open to Dr. Fernandez, on utilizing institutional KL2 programs and then pursuing additional research support through the individual K programs as a way of getting more than 2 years of development time prior to an odd application. How is that viewed by folks at NIH or elsewhere?
Jump in for a minute. We love the KL2 programs. We love K-12 programs. They are an easy for those, if they're available to you, please take a look at them and try to get the interest of the individuals running that program. I think you'll find that it provides a great start. It's also really good for the individuals who never had a T32 training program. They get to a new institution, there is a KL2 program, they then get into that program. It usually takes a couple of years, but they're great programs. They're run by the CTSA, and they're robust. Now, I can tell you also that NHLBI has a great, we really want to bring people up the ladder. We want them to go from K to R. And we actually changed our requirements. Historically, we'd only had 6 years of K funding for anybody. So if you did a K-12 or you did a KL2, you could only have 6 years of funding. That really is tough to get an independent award. We've now extended it, so now you can have up to 8 years of funding through the K mechanism, through two different mechanisms, but it's a really valuable opportunity. And again, you're not locked away for the rest of your life. I'm going to
Jane, your dog is making my dog bark.
That's team science. Can't stop that from happening.
Sorry.
This is Jim Holmes. Let me just add, because I direct our KL2 here at UC Davis, and let me just add that that's our standard for the MD scholars in the program is 2 years of KL2, and then they apply for an independent K award to the appropriate institute. And that's pretty much standard for KL2 programs across the country. PhDs are a little bit different. Their opportunities for independent Ks are a little bit tighter, I guess you'd say. And so that the PhDs in our program typically do not go on to independent Ks.
Or we have very limited numbers.
Dr. Bennett has a question. Chris, you're on. Go ahead with your question.
Thank you for recognizing. I guess the basis of the question, having had the opportunity to speak with some folks in the KL2 program here, as well as people who have done KL2 to K, is I'm currently finishing, or not finishing, I'm currently probably about 25–30% way done with a PhD. So I did my training a little bit backwards. I was a geneticist for several years, did a research fellowship, then went to medical school and then residency. And so now I find myself transitioning in terms of my research portfolio. And so I've built up the mentor network, I'm developing projects, applying for grants, writing papers, but I recognize that a component of being successful will be some protected time to both develop the research that I'd like to do to continue to build my network, but also to finish my PhD and have time for all of this. And so the thought for the KL2 at Stanford looks pretty straightforward, that it's a good 2 years of protected, but the question I had was, when I subsequently apply for a K, is it an abbreviated K that I don't get the full recognition of the KOH, so only get like 2 years compared to the additional, whatever is associated with it? Or do I get the benefit of the full KL2 and the full K? And is that a detriment, or how people sort of look at how that application would pan out for someone who's not necessarily doing a master's, but has a little bit of a longer time with a PhD in the process?
Okay. I would say go for whatever you need. We have people that are PhD, MD PhDs who come and call and they want a K program, and they've already got all the degrees that they need, but they need other areas of training. And so that's the issue. I always tell people also, take as much time as you can in each one of the programs. We're not tying you into a program. It's you take it, you try to get the most out of it, and then you move on to the next program. NHLBI permits up to 8 years of K funding between KL2 and K individual K award. That is phenomenal. That's great. And if you succeed and get plenty of R01 funding, then you can leave your K program, your individual K program, at any given time. I've seen people apply for and get their first RO1 in the second year of their K, and then get their second RO1 in the fourth year. And by year 5, they have to turn around and turn in their K because they have too much funding. Now, to me, that's a success. So nobody's going to tie you into the programs forever and ever. It helps you, though. It's an insurance policy to get you up and started. Does that make sense?
It does. I guess one of the background questions was, is the expectation that when I apply for a K after a KL2 that I'm going to ask for the full
No.
spectrum? Oh,
Not at all. All you have to do is justify why you need this additional training.
Yeah, we've had scholars, Chris, that have applied for only 3 years. I believe 3 is the minimum in a independent K. So we have had scholars apply for just 3 years.
Hi, Jim. It's good to see you on this panel. But my question is, and with 3 years of a K, where are they competitively for RO1 funding?
Yeah, it's a good question, and it's typically people that have done 2 years of KL2, 1 year of institution support in essentially KL2. So they've had 3 years of support in a KL2 type program, and then they need just a little bit more to then make that transition. So they do 3 more years to get these particular skill sets. And so they've had a total basically of 6 years as faculty in K training, and then they are applying for ours.
Okay, great. Thank you.
Great.
But we do tell everybody to apply for as much as possible usually.
Right. So they've got an insurance policy.
So kind of pivoting back to the T mechanisms, Dr. Scott, you mentioned that we have 3 programs in emergency care research, and there are some barriers to establishing a T32, and I think you kind of touched on it. One of the examples that I have heard and seen is that we don't have many late-stage investigators in emergency medicine that have achieved and sustained federal funding or have a strong track record of mentees. There are exceptions to that. I'm talking about most of us. It's not easy to change that landscape in a few years. So how do we as a specialty overcome the barrier and kind of increase the T32 over time?
Okay. I think that there's a lot of strength if, in terms of program leadership, you've got emergency medicine and you line them up with somebody else who's already running a T32 program, a cardiology program, a pulmonary program. Make partnerships, partner with your CTSA, find out what resources are available there and what they can provide you. Find out what resources are at your School of Public Health, your School of Medicine, your School of Nursing. Find out what's available across the board. The T32s, it's going to take a while, but in the meantime, you know, the field has come leaps and bounds. I think most people on the panel would agree with this over the last 15 years. And we have far more RO1 funded investigators than ever before. And so remember that if you don't have the strength of being a PI for a whole program, how could you partner with somebody to run a program? And then subsequently, not all the faculty in your program have to be emergency medicine. They could be neurology, pediatrics, cardiology, anything else, as long as they understand K training, T32 training, and they can mentor people. Does that make sense?
That does. Thank you.
So
And go ahead, Sophia.
Oh, I was actually going to change topics unless you had another follow-up question. Okay, I'd like to kind of pivot a little bit and talk to Dr. Brown. So Dr. Brown, you're an emergency physician. Can you tell us about your research path and how you entered into the NIH?
Sure. So I did my residency in Boston, and even as a resident, I was always interested in research. I was especially interested in writing, still a passion of mine. And so I got involved with some projects as a resident. They were simple projects that are available to any number of people in residency programs across the country. There was nothing, I think, special about the opportunity that I had. I just availed myself of them. I spent a couple of years in Boston, again, as a very junior faculty at the Harvard system, and undertook some investigator-initiated projects, actually looking at the early treatment with Lovenox as an outpatient. And then after a stint in Israel, I moved to Washington, D.C. to take up a job as the residency director there. And that's where I really cut my teeth, if you like, on how we do emergency care research. One of the programs that I think I'm most proud of was setting up the Academic Associates Program. Of course, I wasn't the person to think up that brilliant idea. I think that credit goes to Jim Hollander and others. But I managed to establish a program there, which, for those of you who are not aware of it, is a program in which we get undergraduates, not med students, but undergraduates to, we give them a course. It was a 4-credit course on theory and practice of clinical research. I would give them a lecture each week on different aspects of clinical research, and the rest of the time they would be in the ED interviewing patients and collecting data and enrolling patients in studies. They loved it, we loved it, the department loved it because they got research, they got salary support and money coming in from the money that the students were paying to the university. And so that was one of the projects that I did. And while I was at GW, again, I really focused on getting the department, I think, to a good place in terms of its research capabilities. And after being there for about, I think it was 11 years, about 11 years, this wonderful opportunity opened up in Bethesda, Maryland, which they asked me in my interview why I wanted the job, and said I would move across the United States for this job, but it's actually closer to my home than my current job in downtown Washington. And I was fortunate enough to be selected, and it's been quite a wonderful transition. And I'm really, every day I wake up and I'm excited about the work that I'm doing, including speaking on panels like this, trying to bring emergency medicine research up a notch or two. All research across NIH can do with being up a notch or two. So there's nothing derogatory in that remark. Trying to improve it, trying to make it a big tent for people, trying to be a face for the NIH for people who think it's a scary place and don't know where to start. And today alone, I think I've had, in between various meetings at SAEM, I think I've had 3 calls today with researchers who wanted to talk about opportunities for them to get NIH funding. So that's a little bit about my path. Thanks.
Can you tell us a little bit more about the mission of the Office of Emergency Care Research and your role there, and how we can, how does an early stage investigator who's interested in emergency care research, what type of resources they might have available to them?
Sure. So the Office of Emergency Care Research is housed in the National Institute of Neurological Disorders and Stroke, NINDS. Like Jane is at the Heart, Lung and Blood Institute, I'm at the Neurological Institute. But the office has a trans NIH mission, meaning it is not limited to neurological disorders. My mission is anything that you as emergency care physicians need to get researched, or as was earlier mentioned, cardiologists who are interested in emergency care research, anything that happens really in the pre-hospital emergency department space. That's the mission that I'm here to serve. The office itself was created around 2011. 2012. It does not have any money. It does not make funding decisions, but it is here to really serve as a resource. So if people want to find somebody at NIH to talk to about a project that they have on suicide prevention, but they don't know where to start, they can come to me, or they can go straight to the National Institute of Mental Health. But I'm saying I'm here, for example, in that capacity, if they want to talk about a project on an intervention for stroke, something for otitis media, how to treat ankle sprains better, you name it, if you don't know where to start at NIH, I'm probably the best person to get you to the place where you can have the right decision about submitting your grant. And as well as that, Jay mentioned, I'm very much involved with the SIREN network and a number of other networks as well that are focused on on clinical questions in emergency research. So that's about what I do. So basically, if you have a good relationship with NIH, you have a project officer, you're fortunate enough to have Jane Scott on your speed dial, you don't need me. But if you don't and you need some help, then send me an email, jeremy.brown@nih.gov. We're here to help.
Can you tell us actually a little bit more about, for those of us who don't know in the audience, about the SIREN network and how it supports emergency care research?
Sure. The SIREN network is jointly funded by Jane's Institute, that's Heart, Lung, and Blood, and by the institute that my office is in, that's Neurological Disorders. And it is a funded clinical research network with a central coordinating center for clinical practice, for the clinical side, and a central coordinating center for the data management, and it has 11 hub sites and many, many, many spoke sites. And it is focused on clinical research. That's research that touches patients, usually phase 3 studies that are within the mission of those two institutes, Heart, Lung, and Blood, and neurology. So we're currently doing, we had 4 main clinical trials. We had 2 traumatic brain injury trials, looking at early interventions for traumatic brain injury, including hyperbaric oxygen. There is a 3rd trial called the IceCap trial that is being funded by the Heart, Lung, and Blood Institute, looking at duration of cooling for people who are post-cardiac arrest but don't wake up. How long should we cool them, and what depth should we cool them for? And there was a 4th trial called the C3PO trial. That was a study that we got up and running very, very quickly during the COVID pandemic, looking at convalescent, we are looking at convalescent plasma for patients who come to the ED and they're COVID positive and they have a risk factor. They're not sick enough to go home. They're not sick enough to be admitted, but they do have a risk factor. So this trial randomized these patients to placebo versus convalescent plasma in the ED. It was funded, a complicated way to fund it, but basically it used the SIREN network to perform this study. About 600 odd patients, I think, were enrolled before a predetermined look for futility was undertaken. It turned out that the study was not showing any, that the intervention wasn't showing any benefit. We call that stopping the study for futility. I hate that phrase. I don't think the study was futile at all, nor do the PIs. The study was extremely productive. It tells us that this intervention doesn't work and we can now focus on others. So those are some of the trials that are going on. There are many more in the pipeline. People who are listening to this who are not part of that network are invited to submit their research proposals and ideas to the network. You do not have to be at one of those 11 hub sites or one of the many spoke sites in order to have your project considered by the network. And if the network thinks it's a good fit, you will go ahead and look for funding, typically from NIH. And then if it's funded, it gets performed through the SIREN network. So that's a little bit of the background of this very exciting network that's really doing great things.
That's great, thank you.
Thank you so much, Dr. Brown and Dr. Scott. I have one last question, and then I'll hand off to Sophia for closing remarks. We talked about the T mechanism and the K mechanism. Are there any mechanisms for underrepresented minorities in emergency care research that we should know about?
I can say that NHLBI has a variety of programs, and I think across NIH there are a variety of programs. We have, for example, the Diversity Supplement Program, which is an opportunity for individuals from disadvantaged populations. There's both population and economic, and so a long list of people who can qualify for the programs. What you get to do is you need to work with a principal investigator who has an R01 or other R type of grant, and you ask them to be you want to be a diversity supplement awardee on their program. or affiliated with their grant. And you basically get hired for 2 or 3 years on their grant and learn at the entry level what it means to do research. I've seen people get this, the program runs from high school all the way through junior faculty. And I've seen it very productively used as a pre-K opportunity for individuals who may have gone through T32 and they didn't have quite enough to get into the K, individual K, but they did this and then they're beautifully placed to write a K grant for themselves. We also have a KO1 award at NHLBI, which is for underrepresented minorities. It's a great award. And you know, we routinely fund about 25 to 30 people a year with that award. So, and it's growing all the time. So there are, and now there's a new program across NIH, which is to investigate and ameliorate structural racism. And so there are a number of research programs as well as research training programs that are starting to come online. So please keep an ear out for those programs. There will be research that will be funded related to unequal proportion of resources to different populations.
Thank you. And I think we are past 2:50, Sophia, if you want to offer the closing remarks for this session.
Sure. Well, thank you to our panelists for providing their expertise and their time today. As you can imagine, there's infinite number of questions we could ask, but we only have a finite amount of time to do it in. Thank you to the audience for joining us, and we'll see you soon.
Thank you.
Thank you, everybody, for your time.
Thank you.
Thank you.